Hi, Kevin Henry with Dental Economics. We're wrapping up the World Dental Forum here in China. I'm speaking with Dr. Sjoerd Smeekens from the Netherlands. And Dr. Smeekens, would you give our viewers kind of a taste of what you spoke about here at the World Dental Forum?
Yes, I would love to. If you look at difficult or complex cases, and nearly every case is complex today because we have much more elderly people that don't lose teeth that often or that fast anymore. So, and we have a group of patients with bulimia, anorexia, and we see a lot of patients that have a lot of wear. The problem is that we as dentists, we don't see that in a very early stage. We see that very late. And if we see it late, then a lot of adaptational changes already happened in the mouth. And these adaptational changes is not only one tooth, but we see that all over the mouth. And what I try to show is how can you find these adaptations, because it's very important that you see the etiology of this and that you exactly can see how much tooth moved in what direction so that you know how to treat it. Because most of the dentists think there's tooth substance loss, and we don't, so the teeth get shorter and shorter and shorter. We need space for our restoration, so they open the vertical dimension and then make their restorations. But what we know today, if that teeth get shorter, but they have an over-eruption as a consequence or as a reaction on this tooth substance loss. So that means that we usually, in 95%, the vertical dimension did not change because of these adaptational changes in teeth.
Okay.
So then it's better to not open the bite, since there wasn't any loss, and try to treat these cases without raising the vertical dimension. But that means that we need orthodontics most of the time to put back or move back the teeth where they came from.
So is this something that the general practitioner and the orthodontist should work together on, or
Yes.
specialist? Okay.
Yeah.
So what are some maybe communication tips that you might give for those two to maybe work together with something like this?
Yeah. So if you see short teeth, we know from literature that the regular tooth length, especially, or every tooth has an average. It's not an average, but if you look at the literature, there's not a lot of standard deviation in length and with the length ratio with teeth. So that means if you see, for instance, a central incisor which is only 6 millimeters long, we know there's at least 4 millimeters is gone. And if you lengthen this, then you see if the tooth had an adaptation, so it came down, so the incisal edge position did not change, but the tooth got shorter. So if you lengthen this, for the orthodontist, it's obvious that the tooth is much too long. So then he exactly knows where to place brackets. You have to tell the patient it looks worse to begin with, but we do that at the day you go to the orthodontist. So I make every tooth, because these adaptational changes is not the same in every tooth. So one comes 4 millimeters down, the other one 3 or 2. So the incisal edge position is very irregular then. And then the orthodontist exactly knows where to place the brackets. You can correct the incisal edge so that it looks better for the patient, but after the orthodontist is finished, then you again have these irregular lengths of central or of incisors, because he should not finish the case that all the incisal edges are the same, but the cemento-enamel junction is at the same level.
Sounds good.
Yeah, it's not always that you need ortho, especially then when you have not only a vertical adaptation but a horizontal as well. And if you have to change the inclination of front teeth, that's when you can get the case done without orthodontics.
Well, I appreciate your time. Thanks a lot.
Well, thank you. Thank you.